First of all, thank you for having me on this program. Um, as you know, the president, in his address to the parliament, uh, cover a wide range of issues, and some of those issues included health. In during his address, one of the things that he spoke about is hospital infrastructure. As you know, currently we are building a number of hospitals. So we have hospitals being constructed in Lima, one in Dikendren, one in Diamond, another one at Enmore, one at Bath, and one at number 75. Uh, these hospitals, we have been working on them, and very soon they would be open. So we are expected to open them in 2025. We have also started the construction of a new maternal and child health hospital at Ogle, and this one is also expected to be completed by the end of 2025. And we have also started working on the New Amsterdam Hospital, which should be completed by 2026. We have other partnerships where we are working with those partners to build new hospitals. So, for example, getting financing from the IDB, we're working to build a new hospital at Maruka, one at Keto, one at Camarang, and one at Lethem. And through the Indian government, we are also working to do a new hospital at Bartica. Government of Guyana has also recently taken a decision to add or to redo the new West Demerara Hospital. And so currently that one is out for, we have tendered that one, and we should be closing those tenders in a matter of weeks. So when you think about it, what we have done over the last couple of years is to rebuild our hospital infrastructure. And Georgetown Hospital being our main referral hospital, it's a very complex hospital. So we wanted to make sure that we have capacity where we can decant some of our patients before we undertake any major works at the Georgetown Hospital. So all of those projects that I mentioned um, would be completed, operational. So what would remain is the Georgetown Public Hospital so that we can focus on that in the upcoming years. And of course, once we do that, we will be building a world-class referral center where there'll be lots of specialities that we'll put in that new hospital. With the Human Transplant Organ Transplant Act, Guyana, we have been doing transplant for some time, dating back to about 2011, but we were doing them on a very occasional basis. So we have moved to a point where where we have been doing them occasionally to now where we have a full transplant program. And once we have that, we want it to be compliant with global standards. And those global standards would entail that you have a proper law, you have an agency that would be able to regulate transplant in the country, and that there are regulations pertaining different aspects of transplant. So the law prescribes the composition of the agency, how this works, in tandem with all the other bodies that are necessary for you to have a very transparent transplant program. And so that is what we have put in place with this law that was passed, and we have activated those agencies that the law spoke about. So right now we're doing kidney transplants almost every month at the Georgetown Public Hospital, and the Georgetown Public Hospital has been properly licensed to do kidney transplants. We also have been doing corneal transplants, and one of the things that we are going to add to our corneal transplant program is to develop an eye bank where we can do the harvesting of the corneas from those who agree. We'll be able to harvest that and then use it for patients who need corneas. So this is an advancement in what we are doing, and of course, it would be in keeping with what happens globally. In terms of the mental health legislation, we have passed two pieces of mental health legislation. Our previous mental health legislation were governed by ordinances that date back to 1934. So obviously, what was happening in 1934 was not in keeping with modern mental health practices. So we've upgraded the law, and it allows us to do a number of things. So one of which is to make sure that we embed mental health in our primary healthcare setting, and this is something that the ministry is actively doing, so that patients who come in at the primary care level, if they have anxiety or depression or any one of those mental health conditions, we'll be able to detect it and we'll be able to manage those patients on an outpatient basis. If someone is having an acute episode, well, then obviously they will require hospitalization. And in all of our regional hospitals now, we are making provisions for mental health patients with acute conditions. So they'll have a short stay, and then once they're stabilized, they go back home. We are also in the process, based on this new way of viewing mental health. We are in the process of reducing the amount of patients that we have at the Fort Kanji Hospital, because many of those patients, while they've been there for decades, they actually can go home. There's no need for them to be in that hospital setting. So we've been contacting the relatives of these patients and seeing how we can send some of those patients home. And of course, if they need continued care, we would be able to provide that care, sending personnel to visit them and so forth. So I think with these two pieces of legislation that the president mentioned, this obviously is helping us to modernize our healthcare practices, both in the area of transplantation and in the area of mental health. Up to maybe 2 years ago, not a lot was being done in the Ministry of Health as it regards digital health. So we have taken some bold steps, one of which is to start development of a digital health strategy. That strategy would be completed by December of this year. And under that strategy, we envisage implementing telehealth, for example. Right now, we have 53 telemedicine sites across the country. By the end of the year, we're hoping to move that to about 80 telemedicine sites. And by next year, maybe by mid of next year, to have almost all of our healthcare facilities connected. We want to make sure that this connection is there because it allows us to do a number of things. One, apart from doing teleconsultations, we also use these platforms to train people. So rather than bringing people physically in a space, we can do ongoing training. And so we have been utilizing those that we currently have in the system to do training. We are also using this platform to get persons who are interested in nursing, especially the registered nursing program. And if in their community they do not have internet connection, then they can come to the health center where we have this telemedicine apparatus and can access their lessons on the internet at Coursera and so forth. So they're able to then do their theoretical training. Once they write the exams and pass the exams, then obviously we'll bring them in for the practical component. So this telehealth platform is also being used in this way. A third usage is we're using it to determine whether patients in some of these areas, whether they need to have a medevac. And that is done by a doctor assessing the patient remotely. And if the doctor believes that this patient, we need to medevac them, then we'll do so. But eventually, when we are connected to all the healthcare facilities, this becomes also a way that we can manage emergency medical evacuations. So the system works in several different ways. One, to provide teleconsultation. Secondly, to be able to train people in nursing, for example. And thirdly, it's to make that connection for emergency purposes. We have also, because of the connectivity, we can get timely data. So we're using this system to also do surveillance of diseases, infectious and non communicable diseases. So this is helping us to enhance the work of the ministry in a very positive way. Apart from telemedicine, the ministry is in the process of rolling out an electronic health record. And by November, we should be signing a contract with a company to start the process of developing this electronic health record. We are also going to start training for digital health technicians. That is, if there's a problem with any one of our systems, we would have a set of technical people that would be able to respond in fixing the system. We have a partnership with Mount Sinai, and they will be bringing in faculty to train these technicians. And once they're trained, they would employ them for 3 years, and then they'll transition them to the Ministry of Health. All of this is being funded through the Greater Guyana Initiative, and Mount Sinai is leading this training for these health workers. So we have a number of initiatives on the digital health that we're working on, and those initiatives are really helping us to advance healthcare in Guyana. We have been trying to use telemedicine in different ways, and there are very specialized ways in which we can do telemedicine. So, consultation between a psychiatrist and a patient, uh, that's basically telepsychiatry. We have developed capacity at the Georgetown Hospital, at the pathology lab, where we have special pieces of equipment. So when you take a biopsy and you're looking through the microscope to see what's wrong, um, with this tissue, we can take high resolution images of this slide and then send it out to other partners for consultation. So right now we're sending these slides out to Mount Sinai for a second opinion, and we have been able to decrease the turnaround time um, at the Georgetown Hospital from 3 months to 3 days. So this is having a positive impact on reading samples, making sure that we are accurate with what we're reading. And if we have any doubt, then we have other partners that we can rely on. So that's telepathology. We have also been using digital health to do teleophthalmology. For our diabetic patients, one of the things that we do is to screen the retina of the patient. And that is because we want to see if at the back of the eyes there are any changes. And the only way you can do that is to screen the retina of the eye. Those images, we store them, and we have an AI that can interpret them to see what changes are occurring, not only to the present image, but they can go back and read the past images and see whether there have been changes. And this is helping us to manage our diabetic patients, because one of the complications of diabetes is really people can go blind. And so if we pick up these changes early, then we'll be able to take some remedial actions. So that's teleophthalmology. With teleradiology, what we've been doing, we have been changing out the analog x-rays. That's the ones where you have to go wash the film and all of that. We've been changing that out and replacing them with digital x-rays. So we generate a digital image, and then we share that image at a central processing site in Georgetown, at the Georgetown Hospital, where the doctors there are able to do the interpretation. And then they send back the interpretation to the doctors so that they understand what they're seeing on the image. So because we are doing all of this in a digital format, makes it quite easy. And the patient doesn't have to walk around with a big X-ray film. They can actually have the image on their phone. The doctors would be able to view these images very easily and make that diagnosis. So this is digital radiology that we're currently using. And for some of these images, we're also able to use AI to do the interpretation. The president is accurate in saying that we have had a 100% increase because one of the constraints that we had in the past, many of the regional hospitals, the theaters were not working. So, for example, theaters at New Amsterdam Hospital in 2019, you had maybe one or two functional theaters. Um, in other regions like Region 3, those theaters were not working very well. So, most of the time they were down rather than operational. In the interior of the country, many of the theaters were not working. So, like Lethem Hospital, that was not functioning for a long time. So, we have actually invested um, large sums of money to make sure that theaters at regional hospitals are functional. And for these theaters to work, when people finish their surgery, you have to also have a recovery room, their equipment in the theater that must be there. So we have done a lot of this. And right now, in terms of expanding the amount of theaters that we have, we are currently constructing theaters at Kokwani. We are currently constructing theaters at Sand Creek, Anai, Karasabai, Aishalton, so that we can expand our surgical coverage. Maruka, we have added a theater, so now we are doing surgeries at Maruka. And there are many other places on the coast where we didn't have theater. For example, Maikoni, we now have an operating theater and we are doing elective surgeries. So, because we now have more places where surgeries can be done, we are now increasing the numbers and reducing the backlog of patients. Now, some of this might be very routine surgery, but in other instances, because of the investments we've been making at Georgetown Hospital, they're now able to do very sophisticated surgeries. So some of it include vascular surgery. So for example, an aortic aneurysm, a couple of years ago, we didn't have the capacity to do that. And many of those patients that were discovered with these conditions, they literally would die in our hospitals. Now we are changing that because we have both the human resource to be able to do these operations and the equipment. In addition to that, um, knee and hip joints. We have had several partnerships with overseas groups, especially Operation Walk, and they came in over the years and have trained many of our doctors. And so now routinely we are able to do knee joints replacement, hip joint replacement, and we do this almost every month. We are doing several of them. And then in partnership with Operation Walk, they come over on a weekend and then we do maybe 50, 60 joints together. So this has really been a big boost to our patients who need these types of services. In terms of neurosurgical interventions, we have been doing these as well. And in terms of cardiac interventions, we have been able to do a number of different cardiac interventions, so much so that patients coming to the emergency, if they're diagnosed with a myocardial infarction or a heart attack, as we say, they move from the emergency straight into the cath lab where an angiogram is done. We can locate which one of the arteries are blocked, and then we can stent them. And within 48 to 72 hours, that patient can be back home. So these were capabilities that we didn't have before. And now that we're doing it, literally thousands of people are benefiting from these operations. On an annual basis, we probably see close to 800 persons with various heart conditions, and we provide all of this care free of cost to our patients. So the sophistication of the types of interventions that we've been doing has improved over the last couple of years, and many more patients are benefiting from these types of interventions. So we are very pleased to offer these services, and we'll continue to expand in different areas so that our patients here in Guyana would be able to benefit from the latest types of techniques. And we're buying new equipment. So, the most modern equipment, we are trying to get them into our hospital system. So the investment is really a big one that we've been making over the years. And you can see that in the growth of our budget because we have had, I would say, exponential growth in our budget so that we can provide health care to our population. With our medical treatment program, we have set aside a huge sum of money to be able to help people. So, one, for example, in cardiology, if someone comes to the hospital and they need a stent, then we provide that stent free of cost. We have been able to do that for close to 800 patients annually. We have also, apart from cardiology, we have also been giving dialysis patients $600,000 every year. And we currently have about 450 patients who have benefited from these particular interventions. So there are many, many conditions that people would come to us for help on, and we have been providing that. And so over the last couple of years, more than 8,500 patients would have benefited through this medical assistance program. In terms of medical supplies, we now have between 85 and 90% coverage. And that's a vast improvement because when we took over in early 2020, the coverage was between 30 to 35%. So you can see that's a massive growth. And one of the reasons being is that we have put the resources to be able to buy medicines. Secondly, we have been procuring it in a timely manner so that patients can have access to them at the health center. And we are making sure that the distribution chain, that once it comes in centrally, that it's distributed to the different regions. So in many of the regions, we have now regional distribution bonds from where the health centers can go and pick up their medicines. So there have been a number of changes. And qualitatively, we have also changed the types of medication that we've been using. So, for example, for persons with cardiovascular diseases, we have been using a new protocol called HEARTS. And in this protocol, we're using better medication to control people's hypertension. So I would encourage persons who have hypertension to come out to our clinics because we have some of the best medications now available at our health center. Similarly, we have just completed new guidelines for cardiovascular diseases. And once we have these guidelines, we make sure that we buy the medications so that people can have access to it. And we've been training our doctors on how to use them. We have a similar thing with diabetes, where we have new guidelines regarding diabetes, and we're making sure that these medications are available. We sometimes have a challenge because some of our physicians, what they do is use old protocols. And if they're using old protocols and prescribing old medicines, then those medicines would not necessarily be available in the system. So this is something that we have to guard against because we want people to benefit from the newer medicines. And therefore, we have been upgrading the training of our physicians, not to prescribe the old medicine, but to prescribe the things that are new and more effective. So this is ongoing training that we are doing with our physicians, and we hope that they would stop this practice of prescribing these old medicines because a lot of time we don't stock it, and therefore they'll write prescriptions for people to go to the pharmacies to get these older medicines. So we are hoping that we can curb this practice. But this is a work in progress. We as a government, we felt it's very important that older person can have access to good eye care. So we have been sending out people to do outreaches. We have resuscitated the Port Morant Ophthalmology Center because when we came back to government, none of the theaters there were working. We didn't have proper microscopes, instruments. So we had to retool the entire hospital. And so that now is operational. And what we find is that among older people, many of them require spectacles, but in some cases, they didn't know or they didn't understand that they require spectacles. Um, in other cases, they couldn't afford to pay for the spectacles. And in some cases, they had other eye conditions that were impairing their vision. So we thought by doing a generalized screening of the population, 65 and older, that it would help us in terms of uh, determining those who need spectacles. And if they need spectacles, then the government would give them a voucher worth $15,000 to assist them in acquiring the spectacles. So far, this program has been extremely helpful to a lot of older folks. And I'm happy that so many people have taken advantage of coming out and getting their eyes tested. And if they need a spectacle, they get the second voucher. But we still believe that there are many more persons out there that can benefit from this. And if you're 65 and older and you haven't come to one of our centers and test your eyes or haven't collected the voucher, I'm urging everyone to do so because we want to close out this program by mid of December, right? So if you haven't done your eye screening, please come out and make sure that you get your eyes screened. Now, the other thing when we're checking your eyes, if we find that you have cataract, for example, then we are putting you on a list and then we bring you into our hospitals and then we are able to operate on you for your cataract. And within a couple of days, you go back home and you'll be able to see properly. So this is a service that we've been offering. And for those persons who are living in the interior of Guyana, what we've been doing is making a list, and then we fly those patients out, we operate on them, and then we take them back home. So this is a program that we'll continue to do, but I think it's making a big change for those persons who have had various eye conditions. Now, that's the older persons. We also focus on younger people, that is 18 years and younger. And the reason for doing so, because a lot of our school age children are within this category. And we find that if a child is going to school and not seeing well, then they would not be able to learn properly. And that was why we wanted to screen persons within this age group. And if we detect that you have a problem, then again, we'll give you the $15,000 voucher so that you can be able to get a spectacle. So this is what we've been doing. And again, if there's anyone out there who meet the age criteria and they haven't come for an eye screening as yet, please do so. We'd be happy to work with you and make sure that you get these vouchers. Now, in terms of the other voucher that we are giving for cervical cancer is the number 2 cancer among women. The number 1 cancer is breast cancer. But cervical cancer is caused by a virus, the human papilloma virus. And this is a cancer that if you take the HPV vaccine, we can reduce the amount of cervical cancer that we have in our country. So what we are aiming to do is to make sure that 90% of our population between the ages of 9 to 15 can get the HPV vaccine. So this is something that we are working on, and the HPV vaccine is free of cost. So to all the parents out there, if you have a child between the ages of 9 and 15, then please ensure that they get their HPV vaccine because this is important. Now, while cervical cancer is our focus, among boys, you can also have other types of cancers. And that is why we want both age groups to get the HPV vaccine. Now, for women between the ages of 16 to 45, we have an expanded vaccination program. So if you didn't get it before 15 years of age, you can still get it once you fall within 16 to 45 age group. And if you take the vaccine, it is going to help to prevent cervical cancer from happening. So if you fall within the 16 to 45 age group, please make sure that you come to one of our health facilities and we'll be able to give you this HPV vaccine. Now, the second thing that we want to do is to screen people to see whether they have this virus in their body. And to do that, there's an HPV test. So we have partnered with all the private sector labs, and they have agreed that an HPV test in the private sector is going to cost $8,000. Now, we don't want the patient to pay for this. The government is giving you a voucher for $8,000. And once you're between the ages of 21 to 65, you can get this voucher. You can go to any one of the private labs. You can give them the voucher. They'll do the test for you, and then you'll get the results. If your HPV results is positive, then there are a set of steps that you will take, and we in the ministry, we will walk you through those steps. And this is really to identify if there's any changes in the cervix early so that we can prevent this cancer from developing. If we pick it up early, there are a set of measures that we can take to prevent the cancers from developing. So we really want to urge everyone, we can reduce the burden of cervical cancer in Guyana if everyone between the ages of 21 to 65 come out and make sure that you get your HPV test. And this is for women, right? We want to make sure that every woman between the ages of 21 and 65 to come out and get the test. For men, we are doing PSAs, so to detect prostate cancer. We have new guidelines, and at our facilities, we can do PSAs to check to see whether it's high, which can be an indicator for prostate cancer. But there are other measures also that we'll have to take. So we want to make that appeal to people. That voucher for $8,000 is available right now, and we really want people to go and get themselves tested so we can reduce the burden of cervical cancer in Guyana. We have been talking to a number of partners in terms of development of pharmaceuticals, of vaccines. So as those discussions progress, our intention is that we'll be able to do manufacturing by or before 2030. So we are working with a number of private sector partners to do this. So one of the things that this government did is to look at retention strategies for healthcare workers. And one of those retention strategies would have been that we've increased salaries for all the medical category of healthcare workers. So from community healthcare workers to nursing assistants, nurses, registered nurses, midwives, doctors, and a lot of the allied professionals. So everybody would have received an increase in salary, and I think that is pretty competitive right now. So that's helping us to retain. We also recognize with the expansion that we're doing in the health sector that we'll need more people. So we have been expanding our training programs and we have decentralized these programs. So rather than training everybody in Georgetown, we have been taking these programs to the different regions and training people there. And once we train them, they pass their exams, we have been employing them. So that's another strategy that we have. And we've seen that that strategy is working because we have more people employed at different health centers across the country. In addition to that, one of the major categories that we've been looking at is nursing. So if we continue training people at the three nursing schools that we have, we are limited by the classroom space. We only can train maybe 150 to 200 persons per year, and that's not enough. So we have gone to what we call a hybrid format where we have uploaded our curriculum to the Coursera platform and we have been allowing our students to have access to that platform. By doing that, we are now able to train, we have approximately 1,200 nurses in that program right now. And this year, we're going to take in another 1,000. Next year, we want to take in another 1,000. So over the next couple of years, we want to train at least 5,000 registered nurses. So we have started the process. These nurses, while they're in training, they get a stipend from us. And once they pass their exams, they have a job with us. So that's what we've been doing in terms of expanding training and giving people access. And many of the telemedicine platforms that I spoke about earlier, these platforms are using, we are using it to give people access so that in a community where there was no internet access, you can come to the health center and you can access the internet from there, where you can sit at the health center and be able to access your courses, do your studies, and so forth. We have many collaborations with many different countries. Um, so we have partnerships with Canada. We have been working with York University, training people to do um, hospital administration. We have trained physicians to lead. So there's a physician leadership program that we did with York University. We also have a very strong partnership with McMaster's, where McMaster's have been offering us fellowships. And over the next couple of years, we want to at least send maybe about 30 persons to do fellowship at McMaster's. We have partnerships with universities in Calgary and other places in Canada. So there are several partnerships that we have with Canada. In the US, we have partnerships with the University of Miami. We have partnerships with hospitals such as Northwell, and they have a presence here in Guyana. Many of their residents come to Guyana and they do training here, as well as we send persons to Northwell to do observerships. And that collaboration has been expanding. We also have a partnership with Mount Sinai, and they have a lot of their senior technical leaders who have been working with us. They have done a lot of good work at the Georgetown Hospital to help us to improve the efficiency of the hospital in various aspects. Plus, they have been working with us on a number of other technical areas, including working with us to develop oncology department, develop an oncology center. They've been looking at developing a cardiovascular center. We have been looking at other areas of chronic non-communicable diseases and in several areas of primary health care. In addition to Mount Sinai, we have a partnership with Harvard University where we have been doing a lot of work on infectious diseases. We have some partnerships with George Washington. They have helped us to train a number of people in HIV. And there are many, many other collaborations that we have. In the Caribbean, we'll be working with UWI, and we're signing an agreement with UWI to establish a medical school a pharmacy school, and a nursing school in Guyana. We have, of course, long-standing relationships with Cuba, where we have sent a lot of doctors and nurses, well, doctors in particular, to get training at the undergrad level and at the postgrad level. And they have trained for us also some technical people that is needed in the system. Um, with Brazil, we are now opening up some partnerships with Brazil. With the UK, we have some partnerships. With Europe, we are developing some partnerships. So there are many collaborations that we have, and these help to give our doctors and medical personnel uh, opportunities to train at some of the best centers around the world, and they bring back those skill sets to Guyana so that our system can be upgraded. With School Health, this is one of the programs that we have recently introduced. Right now, we have close to 20,000 children that were screened at the nursery level. And of those that were screened, about 2,000 of them, we saw that they had different problems. And we have brought those children into the hospital system where we're working to fix those problems. So I think that's a good program because our intention is to screen children at nursery, at primary, and at secondary. So now that we are more or less completing nursery, we are now moving on to primary and then we'll go to secondary. We estimate that we'll have to screen close to 280,000 children over a couple of years. And as children enter the education system, we'll continue to screen those who are entering. This would allow us to do a lot of preventative medicine, and that's the intention of this program. And if we can prevent things earlier, then it helps that child to stay healthier and live a longer life. So that's the intention of this program. So again, we will urge parents to collaborate with us, to cooperate with us, because this is to the benefit of your child. And therefore, we really would like to have that support so that these programs can be rolled out very easily. Apart from the school health program, we want to make sure that our population stay healthy. So the president announced a voucher that we'll be introducing next year. And rather than confining people to come to the public health system, if they want to use this voucher to get screening, they can use it and they can determine how they want and what they want to use that for. But I think it's a good thing because we want to encourage people to make sure that they have, um, they go to the doctor, go to different institutions so that you don't wait until you're sick, but you can come earlier. We can do the screenings, and maybe during those screenings, we can find things that we can alert you earlier. But when you present with a disease, it's harder to reverse some of those things because the damage would have been done already. So the idea here of this voucher is to make sure that we test early, we pick up things earlier, and then we fix them earlier so that we are preventing complications from happening. This would ensure that that person stays healthier and live a longer life. That's the intention of all of these programs. I think it has been quite positive that we've removed VAT and taxes because it allows a lot of the private sector now to bring in new equipment to upgrade their systems, which is quite essential if you're going to stay updated with medical practice. So I think this has been helping the private sector, and we have received very positive feedback when we introduce these measures. Thank you for listening and to have this opportunity to be able to maybe uh, expand on some of the items that were touched on by the president during his speech. Because, in a speech, he was touching on all the different sectors, so he didn't have the amount of time to elaborate on some of these. So I hope that I've been able to elaborate on some of them so that you can understand um, the enormity of the programs that we have in health, but more importantly, for you to be able to come and access these services so that you can improve your health. And we really welcome you to come to any one of our facilities so that we can provide the services that we have invested in for your benefit.